Hello and good afternoon, everybody. Welcome to NGPG Quality Grand Rounds. This series is offered quarterly with topics centered around quality and safety. There's no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment of the session. You may enter your questions into the Q&A section. If you're looking for the link for the event survey, that will be put into the chat section toward the end of the program. And now it's my pleasure to introduce our speaker for this afternoon. Melissa Blasingame worked for 7 years as a registered nurse in the Cardiac Intensive Care Unit at Erlanger Hospital in Chattanooga, Tennessee. She earned her Master of Science in Nursing with a family nurse practitioner focus from the University of Tennessee at Chattanooga. Driven by a deep passion for cardiology and preventive care, Melissa now serves as the nurse practitioner for the Georgia Heart Institute Center for Cardiovascular Prevention, Metabolism, and Lipids. In her current role, she collaborates with an interdisciplinary team to deliver comprehensive, patient-centered care to the Northeast Georgia community, emphasizing the prevention of cardiovascular events and the promotion of heart health. Melissa is also one of 15 professionals nationwide to have been selected for the Lipid Scholarship Program through the National Lipid Association, which provides mentorship and training to aspiring lipidologists to work towards certification in clinical lipidology. Melissa, welcome today. Thank you so much for your presentation. We're glad to have you. You can take it from here.
All right, thanks so much for having me, and thanks for the introduction. As she said, I'm the nurse practitioner for you've probably heard us as the Prevention Center, but also we are the Lipid Clinic here at Georgia Heart Institute, and we're going to talk stat and help patients make informed choices. So let's get started. I have no disclosures. And here are my learning objectives, which were noted on the event. So just to get started, talking about indications for statins. I'm not sure how this is coming through on y'all's end. It's a kind of busy slide, but I wanted to show these handouts. They're used with permission from the National Lipid Association. They give a great overview of the primary and secondary prevention guidelines for the treatment of high blood cholesterol. Those are from the 2018 guidelines. I could spend an entire lecture just going over these guidelines, but bottom line is that we need to be identifying our LDL targets for our patients and initiating lipid-lowering therapies, ideally before an ASCVD event occurs or as soon as possible after an event, such as an MI or stroke, or in the case of symptomatic PAD. The National Lipid Association actually has a lot of really good free handouts. Even if you're not a member, you can access all of this. So a lot of good reminders. So why do we care about lowering our patients' lipids? So a good point I like to bring up is that for every 39 milligrams per deciliter reduction in LDL cholesterol, that equates to approximately a 22% reduction in ASCVD events, with increased benefit for those with very high baseline LDL-C. For example, if you have an LDL of 200 milligrams per deciliter, such as in those patients that likely have familial hypercholesterolemia, decreasing to 100 equals approximately a 30% risk reduction. So I think we all probably know the process of how atherosclerosis and thrombosis form, so it's a big thing to point out to our patients when we're having these discussions. And another reason why we care, candidly, is because we have these practice advisories that come up to help us, and I know a lot of us are also under a lot of pressure to meet these requirements for quality metrics and so forth. So we want to do what's best for our patient, and we want to be informed about, how to go about doing this. So that's what we're going to talk some about. So statins and cardiovascular health. So the common theme of the guidelines is that statins are the first-line recommended therapy for the treatment and prevention of ASCVD. Statins, or HMG-CoA reductase inhibitors, inhibit synthesis of cholesterol in the liver and also increase hepatic LDL receptors, so the receptor function. They've been widely used and studied over the last 30 years, are found to be effective in decreasing plaque production and stabilizing high-risk plaque. So, multiple randomized control clinical trials show statins reduce mortality in ASCVD events. They're generally well tolerated, and they have pleiotropic effects of plaque stabilization, reduced plaque burden, and anti-inflammatory properties. Although, some specialists debate whether this is mostly from LDL lowering or whether this is from statins alone. Either way, these effects are very helpful to our patients. And I like to talk a lot with my patients about the plaque stabilization as well as decreasing plaque buildup. I often use the example of, thinking about turning a blister into a callus. So, mixed high-risk plaque is like a blister. It can rupture and cause an event. So lowering our LDL will, again, stabilize plaque, turn it into a callus, as well as, again, preventing more plaque from building up. So most of you probably already know this chart very well. So just to remind you of statins by intensity. So atorvastatin 40 and 80 and rosuvastatin 20 and 40 are high intensity statins. And then I just put H's in parentheses for the hydrophilic statins, which are rosuvastatin and pravastatin, which I'll kind of address a little bit more later. I mostly prescribe atorvastatin and rosuvastatin as they're both longer acting and have fewer medication interactions. But, as I know you've all learned, there are a lot of patients that need to try at least, 3 different statins before they find the right statin, the right dose. Again, we'll talk about that a little bit more in future slides, but just a little reminder. So how to talk about statins with patients. At the end of the day, we have to put the patient first, educate them as well as we can, and find a treatment plan that they're comfortable with. So, using patient-centered language, putting the patient first and using shared decision-making are very important. It's important to make the patient feel heard, like it is in all of our appointments. And, the patient is the expert on themselves, so it's good to emphasize that, but also emphasize the fact that you're here to provide expertise and guidance on the treatment plan so that they can, again, make the most informed decision for them. Different patients respond to different methods as well. It takes an interdisciplinary team to get through to many patients. I'm very lucky in the lipid clinic that, we have physicians, we have me, we have a dietitian, we have a wellness coach, we have our nurse, we have our prior authorization specialist, and we all are constantly getting messages or having different types of conversations with our patients. And sometimes different providers get through to patients in different ways. For instance, I had one patient who came to see me 3 or 4 times, every time saying his daughter would not let him take a statin, every time leaving saying he was going to take the statin, only to come back the next visit with his mind changed again. And he finally saw one of our physicians, and the next time I saw him, he was taking the statin. In reverse, I've had some patients say that as an APP, I had more time in my appointment slot to explain the rationale. So I ended up being the one to convince them to take a statin. So I know it can be a frustrating time having to address multiple times in multiple appointments. That's somewhere that I'm lucky that this is my specialty, but it's something I know we've all had to address a lot in different conversations and different emphasis on different points. Can be helpful in different ways. So again, shared decision-making with that patient in mind. So we'll talk a little bit more about the types of conversations that we have and the common hurdles that often, come up when I am having these discussions with patients, as again, you've all experienced too. So, I know a lot of patients are worried about dementia. There's a lot of misinformation online about a lot of these things too. So dementia, liver damage, diabetes, and myalgia and myopathy are some of the most common concerns we get from patients. So how to address those things. So with dementia, some positive talking points that I often go over in my appointments is that the brain makes its own cholesterol and that brain cholesterol transport is not primarily LDL mediated. I think that's something that patients get hung up on a lot. And then, decreasing LDL cholesterol actually decreases of obviously ASCVD risk, including stroke. So obviously I'm in cardiology. I talk a lot about cardiovascular risk reduction, but I also put a big emphasis on, decreasing stroke risk and decreasing vascular dementia, because I've found that a lot of patients are much more afraid of having a stroke than they are of having a heart attack because of, our technology these days. We get to them quicker and we intervene faster. And so they're a lot more afraid of strokes. So I like to point that out of, all the good things that we're doing to reduce these risks. And then the fact there's, no definitive evidence linking statins to dementia. And then there's actually some studies showing decreased cognitive decline in patients with ApoE4 status. So, at higher risk for Alzheimer's who are on statins. So again, some common concerns: statins do cross the blood-brain barrier. And again, patients often ask, doesn't my brain need cholesterol? So again, I like to listen to their concerns and try to validate their concerns, but alleviate their fears. Another common question I get is, can my LDL be too low? I often like to reference the Ebbinghaus study. It was a study of evolocumab, so Repatha and statins. The patients were either on evolocumab and statin versus placebo, and there was no significant change in spatial working memory and executive function tests compared to placebo. And these patients had LDL as low as 25 milligrams per deciliter. So, that's something I like to bring up to patients too when they worry. Is it too low? Is my brain not going to get enough cholesterol? And pointing out too that many of our organs, again, make their own cholesterol. Yeah. As far as liver damage, again, education and reassurance are important. So risk of statin-induced liver disease is approximately 1 in 100,000. Risk of acute liver failure from statins is approximately 1 in a million. And then non-alcoholic fatty liver disease can increase risk, although it's not an absolute contraindication for statin use. Actually, a lot of those patients, because they're higher risk, higher cholesterol can make their risk worse. So a lot of those patients are on statins, as you know, to decrease risk. So, and then per guidelines, routine LFTs are no longer needed. It's recommended to get a baseline and then recheck if symptoms of liver dysfunction are present. So right upper quadrant pain, jaundice, fatigue, decreased appetite. I will say in our clinic, because, we're try to be a comprehensive, prevention clinic, we do often get metabolic panels with follow-ups. Because we're looking at kidney function, we're looking at electrolytes, we're looking at, fasting blood sugars and things like that as well. So we often do still check liver function, probably more than a lot of lipid clinics would. But again, it's no longer required by guidelines. As far as diabetes goes, so there's a relatively low risk of, getting diabetes from being on a statin. There is a potential for impaired insulin sensitivity and decreased production from compromised pancreatic beta cell function. But mostly you see this in pre-diabetic and insulin-resistant patients who are already kind of heading towards a diabetes diagnosis because of getting their other risk factors in their entire metabolic picture. So it's really a risk versus benefit discussion and close monitoring. So again, I often offer a lot of reassurance to patients because, again, we're decreasing your risk of heart disease or decreasing your risk of stroke and peripheral arterial disease. So I try to, again, alleviate people's fears about the off chance of having their blood sugar increase. And again, that's one of the reasons why we do often get metabolic panels to follow up on patients too. It's partially peace of mind in our close monitoring. As far as myalgias and myopathy, so the 2018 AHA-ACC Multi-Society Cholesterol Guidelines on statin-associated muscle symptoms, just offering some definitions. So myalgia had a normal CK. For myositis and myopathy, so the CK was increased with objective weakness and symptoms concerning for myopathy. And then rhabdomyolysis was a CK greater than 10 times the upper limits of normal in renal injury. So, thinking about the right terminology, especially when you're documenting a reaction, which we'll talk a little bit more about with the best practice advisory again. It's important to think, is my patient having myalgia, or are they truly having myopathy? Or again, rhabdo, a lot more clear. They're generally hospitalized. So, but for documentation purposes, that can be really helpful too. And then, so talking about the different types of statins with patients. So lipophilic versus hydrophilic. So there is some thought that potentially hydrophilic statins are less likely to cause myalgia and myopathy. So that would be rosuvastatin and pravastatin. So trying with your patients to try an alternate dose or an alternate statin can be really important if they are experiencing some muscle symptoms. And trying to point out too, it is generally, bilateral symptoms. Trying to think about how they felt before they started taking the medication is really important. I like to talk to my patients about that. Were you having prior muscle pain from an injury? Are you having any autoimmune disorders or anything like that that have already been causing muscle pain or joint pain? And trying to kind of get a clear picture of, is this actually worse than when you started taking it? Or is it because everybody in your family has told you, don't take statins, they're going to cause muscle pain, that you're now having that nocebo effect? So something good to kind of take inventory of ahead of time. And again, if they're on atorvastatin, maybe try switching to rosuvastatin or pravastatin, vice versa. Not everybody tolerates hydrophilic better than lipophilic. Patients are different. And then, especially in your lower risk patients, so not your super high risk straight after an MI, but in your more primary prevention or high risk but not very high risk patients, even we've been trying lower dosing more often, especially patients who are very leery or have every family member they've had has had a bad reaction to statins. Even trying, as low as like Crestor 5 milligrams every other day, and just working your way up from there. And I'm sure many of you know that, once patients are on, a moderate or high intensity dose of a statin too, it's really important to think about not necessarily increasing the dose if they're not very close to their goal, because you generally, a rule of sixes, you usually only get about a 6% additional reduction in your LDL from increasing the dose within the same, intensity range, but they're more likely to have some kind of side effect from the medication. So these are all kind of things that we think about. And, per the guidelines for having statin-associated muscle symptoms to be statin intolerant, patients do need to fail multiple statins and at least one at the lowest dose to kind of justify moving on. Now, not every patient is going to agree to try, 2 to 3 statins, but that's why we try to have those good patient-centered talks and talk it through. Another big thing I know patients talk about is taking CoQ10. There's inconsistent data on CoQ10 supplementation, although it's not harmful. A lot of my patients will take it, and if it kind of makes them feel better, and again, it's not harmful, a lot of times I won't discourage it. We kind of see on a case-by-case basis. For vitamin D, recent studies have shown no difference really in statin alone versus statin with vitamin D supplementation, although these patients were not all vitamin D deficient in this study. So It's still not a bad idea to check your patient's vitamin D level and make sure they're not deficient. Um, and then, thinking about predisposing factors too when you're deciding on your dosing and your choice of statin. So, age, female sex, low BMI, high risk medications or comorbidities like HIV, renal, liver, thyroid disease, or pre existing myopathy, and even like Asian ancestry, excess alcohol intake, and high levels of physical activity are all things to kind of consider. Is this patient more likely to have some kind of myalgia? And then again, talking about the nocebo effect, I feel like I selectively will discuss this with my patients, kind of feel them out depending on what kind of feedback they're giving me in our discussion. But, there have been studies that have shown, patients on placebo on high intensity statin, and they swap throughout the trial. So it's a N of one study where basically they reported similar amounts of myalgia and muscle pain on placebo versus being on statin. So there is just such a bias, as we all know, about taking statins these days, that a lot of patients really do just assume that they're going to have a bad reaction. So again, I try to, by the time they come to me, a lot of times they're already skeptical or they've already tried other statins. So I try to talk to them about keeping an open mind. Um, but again, reinforcing that I'm listening to my patient. If they have side effects, I believe them, and working with them to figure out what plan works best for the individual. So again, more common anxieties. Patients ask very often, is this for life? Um, you know, Patients have I feel like a common anxiety about thinking that like, why can't I do it all on my own too? A lot of patients, you're like, I'm healthy, I exercise, I eat well. Why can't I just control this without medication? And I think there's a common idea that taking medication is somehow, losing for certain patients. So I try to talk to them about, we're lucky that we have our dietitian and our wellness coach who's an exercise physiologist to help with the lifestyle coaching. And in some patients, if they do lose weight and they change their diet and they're more active, then there is the potential that we could decrease their medication dosing. But I also like to point out that if they're high risk or very high risk, there are these, again, pleiotropic effects of the medication and keeping their cholesterol down to prevent even worse disease down the road. So again, kind of changing that mindset of it being some kind of weakness to have to be on a long-term medication and reinforcing that if you stop the medication, obviously the effects will go away unless you have made very drastic lifestyle changes. And you also have to think about patients who have familial hypercholesterolemia or even a inherited likelihood to have a slightly higher cholesterol. I mean, some of the goals that we're setting now that we know are great for prevention are not attainable easily by many people on their own. So getting an LDL less than 55 or less than 70, it can be very difficult. So reinforcing too that, especially in those familial hypercholesterolemia patients, like it's not their fault, especially when they're doing all these other things right. Sometimes the reason that patients are living longer is because we have medications to help combat these genetic things. Yeah. And then as far as promoting adherence, again, in very anxious, lower risk patients, start low and go slow. So again, try to start at a very, very low dose and slowly kind of work up. I mean, I've been very surprised. The averages of LDL lowering are the averages. I've had patients surprise me where I've had them on, again, like 5 milligrams of Crestor every other day, and they've gotten close to a 50% reduction in their LDL. And we didn't need to go any further. So just, again, trying to work with patients, especially when they're very anxious and you have to have a long talk with them to even get them to agree to start a medication, because if you just slap that high intensity statin on them right from the start and they immediately have side effects, most of those patients who are already so distrusting are never going to try another one. And then again, trying the hydrophilic versus lipophilic. And then changing time of day, dosing, and frequency for adherence. That's especially, again, in the longer acting statins. I know a lot of patients think they have to take it at night, but with those longer acting statins, I tell my patients, whatever time of day that you're more likely to remember to take your medication is when I want you to take your medication. And then, some patients who are maybe having very mild muscle symptoms too that don't seem quite, again, not in that myalgia, myositis, sorry, range, maybe take the medication at night because they'll be asleep and they won't notice it. So again, kind of work with them, see what works for them. And then again, check vitamin D and consider CoQ10 for certain patients. So back to shared decision making. Ultimately, you may provide all the evidence and logic, but your patient may still not be open to trying certain medications. So, again, it's very important to make patients feel heard, give them all the information you can, but at the end of the day, be respectful of their decisions. I can't count the number of patients I've had where they were adamantly against statins. They had read all the online conspiracy theories. They, were convinced that they were terrible, and I listened to them. We took a beat. We tried some other things first, and they felt like they had been heard. They didn't feel like I was just someone trying to push a medication on them. So we came back later and they ended up agreeing to try, a low dose statin because they didn't feel like, again, they felt heard. They felt like it was their decision, as it should be. And again, some patients are going to decide not to try them and they're going to adamantly refuse or adamantly refuse after one. And that's, again, it's their body. It's their choice ultimately. So you got to work with people where they are. So whoops, sorry, this slide did not turn out. Hold on one second. It was working earlier. There we go. Sorry. So with statin intolerance, so there is a statin intolerance tool I linked. I think it was in one of Alex's presentations that she had shared as well. And then again, thinking, so that's a good thing to use when you're trying to determine, like, is my patient truly statin intolerant? It gives you a lot of good data to look at to see, again, is this a legitimate intolerance or should I maybe try and talk through trying something else? And then, yeah, again, the definition is trying and failing 2 statins, at least one at the starting dose. And then there's, partial versus complete intolerance. Exclusions to document. So this is important for our charting. So when you get that practice advisory come up, that shows you, or our practice advisor that is saying this patient needs to be on a statin. So exclusions that are important to document are patients who are pregnant, have had IVF, or are breastfeeding at anytime during the fiscal year. Patients who have a diagnosis of rhabdo at any time during the fiscal year, a documented allergy to statin, including intolerance, put it in the allergy field. So and it's nice too if you put which statins they've tried, especially if you end up sending them to lipid clinic eventually, because that's really helpful for insurance companies for getting alternate therapies approved. And then palliative or hospice care, obviously, end-stage renal disease coded in the fiscal year, statin-associated muscle symptoms coded in the fiscal year, acute or liver or hepatic disease or insufficiency, and then important is statin intolerance does not count. So a lot of people will document that, but you do need to put, like myalgia due to statin-associated muscle symptoms, these other examples. And this was just, it's a little bit blurry, but in this presentation, but the tool that this links to is really helpful. So again, it gives you like a rhabdomyolysis assessment. It goes over different muscle symptoms. It goes over secondary considerations to think about. And then also there's a section for current statin drug interactions. So it helps you really think through what's going on and how do I process this. And then that's, again, just an example of everything that you can document. So again, palliative care patient. You can also document if the patient refused to put a note about it, but hepatic insufficiency, end-stage renal, and then if you put the allergy in, this will go away too. So yeah, just a reminder. And then this is a reference guide I made again on my PowerPoint. It was coming through more clearly. I'm not sure how well y'all can see this. It combines the guidelines, the 2022 Expert Consensus Decision Pathway and the 2024 National Lipid Association Expert Clinical Consensus on the role of ApoB in management of CV risk in adults, along with pharmacotherapy recommendations. So just to go over alternate pharmacotherapy, so when your patient truly can't tolerate statins, so think about ezetimibe. So cholesterol absorption inhibitor decreases the gut absorption of cholesterol, lowers LDL by 18 to 25%. And then there are the PCSK9 monoclonal antibody medications, so alirocumab and evolocumab. They lower by 45 to 64%. And as a side note, not on label, but were shown to lower lipoprotein little a by 20 to 30% in clinical trials. PCSK9, so the siRNA is inclisiran or Leqvio. We administer that in our lipid clinic. It's clinic administered. It's really great for patients with Medicare, especially. Lowers, again, 48 to 52%. And then thinking about bempedoic acid, which can come in a combination pill with ezetimibe, lowers by another 17 to 18%. And then bile acid sequestrants, often not as well tolerated, not as commonly used because of the GI side effects, but still, I mean, when you are trying to throw everything at them, that's one thing you can use. So again, when statins aren't enough or when they don't work for your patient, there are alternatives to consider, and obviously consider referring to your friendly lipid clinic if you have any issues with this as well. And then lifestyle is still important as well, just as a last note. So just remember, alongside lipid-lowering therapy, to still recommend diet and exercise. We generally recommend a Mediterranean diet. And, the AHA recommends 150 minutes of cardio per week, baseline, plus strength and stretching. Our team actually received a change grant to provide Med-South cookbooks and foam rollers to our prevention patients. Also have free foam roller classes, a walking club, a weekly newsletter with healthy tips. But you can also access the Med-South cookbook for free online through the UNC's website for patients who need ideas. So it's basically Mediterranean type meals with Southern flavors. So that has been really helpful because a lot of patients say they think that Mediterranean flavors are gross. So that's been a cool thing. But yeah, just as a last note. So ready for questions, and there are my references too. Thank you all so much for being here and for listening.
Thanks so much.
Thanks, everyone. Have a good rest of the day.